Hi, and welcome to the Future of Dermatology podcast. I'm your host, Dr. Faranak Kamangar, board certified dermatologist. We are here to talk about anything and everything dermatology related. You'll hear from me and my guests who are dermatologists, physicians, experts, scientists, residents, and medical students in the field of dermatology. We publish weekly, so if you like what you hear, hit that subscribe button and show us some love, and thank you for joining us.
All right, let's continue on with our Dermatometabolic series. We're talking about signs of metabolic dysfunction, how we can recognize it in clinic, and then how can we test for insulin resistance. So we have some slides up with this one as well. So if you're listening on any of the podcast platforms, if you'd like to switch over to YouTube, you could also see the slides, but I'm going to try to be very descriptive. So if you're just listening to it, I don't think you're missing much. So signs of metabolic dysfunction. Obviously, the main one we talk about is obesity. We know nearly about 70% of adults are now overweight or obese in the US. And sadly, our little ones, our children, are following that trend as well. Obesity is not always necessarily very visible either. There's also sarcopenic obesity, which we're not catching as much. This is what we call skinny fat. So you have a normal BMI, which is also where the BMI is a little bit limited in being able to fully understand metabolism. You might have a normal BMI, but you have an abnormal composition. So if you look at what makes up your body, you have a low muscle amount and you have high fat. That's called, you might look kind of skinny from the outside, but that's also considered obesity, which we're not catching as much. So if we try to pick up sarcopenic obesity, where we'd have to do body compositions on everyone, that number of 70% is probably going to be even higher. So patients with sarcopenic obesity also can have metabolic dysfunction. The reason I bring that up is because you might see a patient with, let's say, psoriasis or hidradenitis suppurativa or other conditions where we've been trained and we know that there's a higher amount of diabetes associated, metabolic disorder, but doing a visual or doing a BMI is not enough. I think it's still in those conditions where we know metabolic condition is high, we should still test for insulin resistance. I like to make the argument that maybe for most of our patients with any kind of inflammation on their skin, we should be doing this, especially like, let's say, your acne patients, and rosacea patients. So it's if you have inflammation, there might be a metabolic component to it. And I think this is a paradigm shift that we're going to understand a little bit more over time. Then also response to our therapies. So if we have, let's say, a patient with psoriasis and we put on a biologic, we know that if their BMI is higher or if they have more obesity, they might not do as well with the therapy. And we've traditionally kind of thought that, well, maybe it's weight based, like kind of like how medications for children are weight based, that the dose isn't right. But maybe there's more to it, right? Maybe that the metabolic dysfunction is counteracting the effects of the inflammatory medication. And then, so what about our patients with normal BMI who are failing our psoriasis biologics or small molecule inhibitors? Maybe when you're failing therapy, we should start thinking about these things. Is there something else going on? This is a phenomenon I kind of found a few years ago. I started testing my younger patients with starting isotretinoin, where their triglycerides shot up really fast. And that's usually not a normal situation in a young patient, especially a teenager. And we know most of our patients on isotretinoin do just fine and their triglycerides never go up, but some do. So what's going on there? And for those patients, I did start testing them for insulin resistance, metabolic dysfunction, and more likely, I was finding that there was something going on there that is important for us to intervene on, because not so much just for their teenage acne, but this child is being set up for high risk of cardiometabolic disorders, dementia, Alzheimer's, all sorts of things, down the line. So, I mean, not to say that those things are exactly correlated, not meaning, just to scare anybody, but we know that with metabolic disorders and metabolic dysfunction and metabolic syndrome, you just have a higher rate of those things down the line. So we need to recognize it and fix it and treat it. So why do we have all this metabolic dysfunction? It's multifactorial. There's not any one thing. And sometimes it's just down to genetics more than anything else. But we do know our food is not helping, right? So we have a high glycemic index ultra processed food type of diet, this Western diet. This type of diet, high glycemic index foods, and if you don't have the slides, there's a picture of like corn dogs and funnel cakes and donuts, all the stuff actually that's delicious. But it rapidly raises our blood sugar and triggers insulin spikes that promote fat storage. And then they create hunger sooner after eating, which leads to overconsumption. Like you're like, oh, this is good. I need more of it. And then your sugar crashes because you have all this insulin. And then the insulin, what it does is pushes sugar into your cells, which is what it's supposed to do. And then you're hungry again. And when you're hungry, you don't want like broccoli, you want more of the funnel cake. So that's part of the problem. Then high fructose corn syrup in itself, that ingredient, it's hidden in a lot of places. That's the tough thing. I mean, if you look at ingredients and you see high fructose corn syrup, that's one thing, but a lot of times it's actually hidden. You could even Google high fructose corn syrup and what other names it might come under. This is like a terrible ingredient. Avoid this. I'm even at fault for I give it to my kids unknowingly and sometimes even knowingly, right? You're out and they're whiny and you just sort of like, here's the chips, just eat it and stop bothering me and being hangry. But what it does is it overloads your liver because glucose or sugar is used by all the cells in your body, but fructose is primarily processed in the liver. So when you have this, you're just slamming your liver. This is how you end up getting fatty liver disease and increased visceral fat. And then just overall caloric surplus. So regardless of the source. We nowadays have sedentary lifestyles. We sit, we snack. You just get a lot more calories than we should. Portion sizes have grown a lot over the decades. Physical activity has come down. And then just food environments promote the convenient thing and the hyperpalatable option. I mean, one thing that we do in our office is our love language with our medical assistants, our nurses, is getting each other those like sugary drinks from Starbucks and Phil's, and then donuts show up. I'm accountable for a lot of it. I do a lot of Phil's runs. So, our love language has become unhealthy. And so let's understand insulin resistance. So what happens is you take in glucose into your body, the pancreas releases insulin to lower your blood glucose. These are normal responses. Insulin helps get the glucose into your cells because your cells need glucose for energy. These are all normal things, right? If we didn't have glucose, we would like not live. We need energy. So these are all normal things that are happening. And then the issue comes when insulin resistance occurs, when this system fails. And how does this happen? So the traditional model, we now know it's a little bit different. There's a newer model. So the traditional model was that insulin resistance came first, and then you got increased insulin. So that means like your cells were less resistant to insulin. And because your cells more resistant to insulin, then your pancreas shot out a lot more insulin, and then you got this hyperinsulinemia, and then your pancreas would put out more and more insulin, and then the beta cells in your pancreas that are creating or secreting the insulin got exhausted and just died out, and that's when you were not able to make any more insulin, and that's type 2 diabetes. The new model is actually that it's not so much the insulin resistance is the first problem, it's actually that a lot increased insulin, hyperinsulinemia is the first step. So you're eating all this food and you're getting just super increased insulin production and release, which is normal because if you're getting a lot of sugar in, you need insulin. Then you form insulin resistance, then you get beta cell exhaustion, and then type 2 diabetes. That might sound similar and you might say, well, who cares? Who cares what comes first? It's bad, but no, what matters here is this shift in our thought that we used to follow hemoglobin A1C and we still do. And then if it gets to a certain level, then we start to say, oh, it's getting really high and you're pre-diabetic and now we need to be careful. But really, that's the wrong way to think about it because your hemoglobin A1C is your average of sugars over the last 3 months, right? So that number is going to stay normal as long as you're putting out enough insulin, that hyperinsulinemia state. And younger people do this even better because they have these robust beta cells that are going to compensate. So no matter how many donuts you throw into the body, they're going to put out more insulin. So your sugar is going to be fine. So a person who's eating a really garbage diet and has just extremely hyperinsulin, is still going to be fine and show a normal hemoglobin. And not only fine isn't healthy, I mean, their test score is going to be fine for their glucose because their body is compensating. But it can only compensate for so long. You're going to burn out your body. So if you have this chronic hyperinsulinemia, you're going to start to get insulin resistance. And my point here is that instead of testing hemoglobin A1C and waiting till your sugars get abnormal, which is a later stage problem, we need to start capturing the earlier issue, which is that insulin resistance, which shows that your glucose metabolism is starting to go awry. So, how can we do that? A common score that we could do is the HOMA or HOMA IR. Let's take a peek at how we can calculate that. And then, so you might ask before we calculate that, why should we care as dermatologists, right? Why should we do this? I think actually all physicians of all specialties should start to do this because we don't have enough endocrinologists is the main reason. But also because it helps us too. So we know for us, insulin potentiates inflammation, right? Via the insulin receptor. So we need to understand what the insulin is doing. We need to understand how healthy our patient's metabolism is before we're even starting biologics, small molecule inhibitors. We need to have an understanding of how their engine is working underneath before we start messing with it. So I think it's absolutely part of our purview to be checking these things. And then once we address insulin resistance, we can actually improve inflammatory skin disease. So it's another tool for us in addition to all the other treatments we have. Then we can modify a patient's cardiovascular disease. And that's great to do. We're not just trying to fix your skin, but I want to make sure you live longer and happier. A practical tip is actually if you have evidence of significant insulin resistance documented by your labs, I can probably get you into an endocrinologist faster. So just a practical tip of working the healthcare system. And then also, we know that insulin resistance is associated with fatty liver disease and can lead to obesity. So I think it's important for us to know if our patients have altered metabolism or fatty liver disease, especially if we're going to be putting them on medicines. We need to know what their liver is doing and how their liver can metabolize medicines we give them. So let's say we're giving them methotrexate, isotretinoin, even oral Lamisil. We should probably know what's going on with their liver at baseline before we start adding more insult to it. And then we can also predict their therapeutic trajectory, like how well they're going to do on a biologic. So this is how we assess insulin resistance. Two ways. There's sort of the cheap and dirty way where if they've already checked their lipids, you can take their triglycerides and compare it to the HDL. So a triglyceride to a HDL ratio. That gives you an idea of how well their metabolism is doing. I like to do the HOMA-IR, the HOMA-IR, the homeostatic model assessment for insulin resistance, because I feel like it gives you more of a value that you can follow over time. It's fancier, and again, it'll get you into your endocrinologist faster. And so what is this score? So this is for a patient with a normal hemoglobin A1C. So you wouldn't really do this for a patient with an abnormal hemoglobin A1C because you already know they have insulin resistance. You already know they have metabolic dysfunction. But let's say they have normal hemoglobin A1C and signs of metabolic issues. So what are signs of metabolic issues, right, that come into our clinic? I think if they come in with psoriasis or hidradenitis or really bad nodular cystic acne, hirsutism, all the classic things, I think we're suspecting metabolic issues. So for those patients, I would check this. So you check the fasting plasma glucose, and they need to be fasting for 8 hours, no exercise or food. Check it in the AM. So check the fasting glucose and check the fasting serum insulin. You're going to multiply those two numbers and divide it by 405. So basically your normal insulin should be about 5, your normal fasting glucose should be less than 100. So your HOMA-IR score should normally be less than 2. If it's elevated past 2, then you know you're having problems. What about the triglyceride HDL ratio? So if they've already had a lipid panel, then you don't need to order more labs or follow up on labs. But if their triglyceride to HDL ratio is more than 3, that's kind of a rough, dirty estimate of they're probably starting to have some issues. And so let's understand metabolic disease in dermatology. So, like we talked about, we have our classic conditions. I think psoriasis is kind of like our main condition that's been studied a lot. Other conditions, it's not that they don't have the association with metabolic disorder, we just haven't studied it as much. But hidradenitis is maybe a second after psoriasis. Then we have our classic findings like acanthosis nigricans, or like let's say a lot of skin tags, and not like one skin tag. This is if you have an eruptive, a lot of skin tags. Rosacea, androgenetic alopecia, acne vulgaris, vitiligo, are cosmetic patients who are aging a lot, aging very prematurely, right? It's like you see like a 30-year-old and you're like, man, your skin looks like you're 50. There's something going on there. So all aspects of our clinic, we can see someone's skin and pick up maybe your metabolism isn't quite right. This next slide is showing a slide from the National Psoriasis Foundation. It's the clinical consensus on psoriasis comorbidities. This came out in 2008, just showing that for psoriasis, it's been kind of our like flagship condition associated with metabolic syndrome. We know there's been a lot of papers that have come out. Dr. Abra Armstrong did a lot of great studies about the correlation of the cytokines and the cardiovascular system. When our new medicines come out, we monitor for MACE, or major adverse cardiac events. So this is a world that we still, even for psoriasis, we don't fully understand, but I think we're a little bit more advanced than other conditions, so we can kind of use it as a model of understanding metabolism in other conditions. The next slide here just shows a paper from JAMA Derm in 2013 showing systematic review showing that psoriasis is absolutely correlated with insulin resistance, and patients with psoriasis have an increased risk of diabetes, and the risk of diabetes increases with their psoriasis severity, meaning like the more psoriasis you have, higher risk. So there is that association there. And psoriasis patients with significantly more insulin resistance, they match, the controlled match them with age, BMI, and even hemoglobin A1C. And psoriasis patients seem to have more insulin resistance than their matched controls or matched cohorts. So it means just having psoriasis by itself is somehow increasing your risk for insulin resistance. And the next slide is showing two different studies showing that weight loss does improve psoriasis. On the left side, we have a paper from JAMA Derm showing just regular weight loss with just restricting your calories. So eating less, but also going through this clinical trial, which we know just even placebo, you're going to lose some weight if someone's following you and monitoring your food and all of that. So if you lose weight, psoriasis will get better. On the right side, there are some of the meta-analyses looking at the glucagon-like peptide receptor agonists, or GLP type medications. We know the studies with GLPs, and then there's now ongoing studies with tirzepatide, which is GLP and GIP, that with the GLPs, your psoriasis will also improve. And it seems like it's improving a little bit more than just the good old losing weight, like the studies that showed weight loss and improvement in psoriasis. Some say, well, it's just because these are better at weight loss, so you're losing more weight. It's possible, but it's also possible that maybe GLP is doing something in itself in the anti-inflammatory sense. And so these are interesting things that we're going to know over time. So GLPs seem to be kind of better at improving PASI. There's one theory that they're just, better at weight loss, but theory two is that we know GLP receptors are expressed on immune cells, including macrophages, dendritic cells, and their activation has been shown to attenuate systemic inflammation through modulation of factors like nuclear factor kappa or NF-kappa beta and inhibition of pro-inflammatory cytokines. And we know there's preclinical studies that show that GLP-1 receptor agonists suppress Th17 mediated immune responses, which we know that's a key driver of psoriasis pathogenesis. Why does this matter for us so much is because we kind of need to understand, is it the weight loss or is it GLP? Because we have other medicines coming out, like tirzepatide is already out. It's a twin incretin, which has GLP and GIP. It does look like the tirzepatide study is actually doing really well for psoriasis too. We'll see those numbers when those are out. And then triple Gs are going to be coming out. And that's going to be GLPs, GIPs, and glucagon. So the reason it matters is, well, you might say there's GLP in all three. So what does it matter? If GLP is effective, then GLP is in all three. But the affinity for the receptor changes. So your GLPs like semaglutide and liraglutide, they have the highest affinity for the GLP receptor. And then when you go to the combination medications, the GLP affinity decreases. So it's just important over time for us to start understanding, is it just the weight loss? And so whatever is going to get you to lose weight the fastest is going to be the best? Or are we going to have to, for our specific dermatology medications, really either do like a GLP or GLP and GIP, or maybe we'll find effects on glucagon are better. So these are things we're going to find over time. And the next slide is one of those slides that everyone shuts their brain off. So I won't go into in too much detail, but if you're on YouTube watching this, you'll see it. But this is the metabolic targets in inflammatory skin disease, and it's basically a giant mechanistic in showing a cell with a TNF receptor, and then insulin growth factor, and then your insulin receptor, and showing how these pathways are all connected. And your cytokines. So insulin is pro-inflammatory. It directly activates your RAS, MAPK, PI3K, AKT pathways by the insulin receptor. And then we know all of our skin cells, keratinocytes, express full insulin signaling cascades. We know we've had a series like treatments of psoriasis with etanercept or Enbrel showing improvement of insulin resistance. So we know these pathways are connected, and we need to understand more and more how they're connected. It's almost like the brake and the gas, right? Like a lot of our therapies now are targeting TNF, IL-23, IL-17s, but maybe over time we need to be throwing a little bit of your metabolism in there and blocking maybe some GLPs. Maybe in the future we're going to have a GLP plus an IL-17 or IL-23. I'm just throwing those out. I haven't heard of those studies happening, but I think that's what the future holds. Hidradenitis suppurativa is another classic treatment that we know that has insulin resistance. We know the prevalence of insulin resistance is higher in patients with hidradenitis after you adjust even for age, sex, or BMI. And hidradenitis suppurativa is an independent risk factor for development of insulin resistance. So like I mentioned, who do you test for insulin resistance? I think everyone for HS you should, even if they have a normal hemoglobin A1C, even if they seem, to not be obese, have a normal BMI. HS itself is a condition that is a risk factor. So you should test their insulin resistance. And then there's a lot more, I'm not going to go into great detail, but there's a lot of studies coming out with GLPs to treat hidradenitis, and that might end up being first line for HS. And so next slide's going to talk about the Western diet, and it's also showing some mechanistic figures here of how the Western diet imbalances, induces imbalances of FOXO1 and mTOR signaling. And we know mTOR signaling is going to promote your sebaceous gland and your sebofollicular inflammasomes that lead to acne vulgaris. So we've known for a while that diet is correlated to acne. Our patients have been saying it, and we're like, no, just here's your Accutane, which we're probably still going to do because we're going to treat your acne, but it does matter. Diet matters 100% with acne. We know that highly refined carbohydrates and simple sugars promote hyperinsulinemia and obesity. Milk increases insulin levels. Also, there's a little bit of debate of maybe it contains low levels of androgens. I don't think that's as big of a deal, but it's really just the insulin. So our patients with like mild acne, you don't have to go too crazy if they have a few comedones, but our patients with really inflammatory nodular cystic acne, we should 100% be checking them for insulin resistance, regardless of age, right? There's no, oh, they're too young. Our kiddos, like really young kiddos, are showing insulin resistance. It's gone, down to really, really young ages. So I would not hesitate if you're seeing acne, especially actually in the kiddos that are younger, test them for insulin resistance and really work with a nutritionist. The next slide is kind of esoteric. It's talking about JAK inhibitors and how they induce acne. It's just to show the same mechanism that acne is one of the mTOR C1 driven diseases. And JAK inhibitors help accelerate the activation of mTOR C1 in adipose tissue by suppressing the STAT pathway. That's the proposed mechanism of how they lead to acne, if you were wondering. Because I remember first when JAK inhibitors came out, I was like, how is this acne happening? And that's how. And the next slide talks about proposed mechanism of metabolic dysregulation for scarring alopecia. I'm not going to go too in depth into this because if you're listening to this, you're probably already bored from me saying cytokines a lot. But we know lichen planopilaris has been associated with decreased expression of PPAR gamma. So, and we know we have medications like piclidazone that can be helpful. So you can always look up this slide, but there is a whole mTOR pathway involved here as well that we're just starting to understand. And then we know poor metabolic function leads to inflammaging. Premature aging is a signal to monitor metabolism, right? So we know this is how you age. You get cell senescence. Your fibroblast collagen matrix metalloproteinase says this is how it works. If you're looking at the photo, I have a picture of a really happy fibroblast fully stretched with collagen fibrils that are connecting it to other fibroblasts and the extracellular matrix. And on the right side is a really sad senescent fibroblast that's lost all of its connections. Metabolic dysfunction will age you faster than anything else and lead to this inflammation and inflammaging that breaks up all of your collagen. Your skin will look terrible. Glycation will form wrinkles. Oxidative stress will dull your skin. The loss of elasticity is going to cause sagging. And that's cosmetics, but medically, you're going to get poor wound healing, ulcers of the lower legs, ecchymoses or bruises on your forearms, and super itchy. That's itching of our elderly, right? They have a lot of these senescent inflammaging that happens when your skin's not acting right. It starts getting super, super itchy. All right, that's it for the mechanisms of metabolism and the skin. Don't forget to listen to our other episodes because we're going to go in depth into the GLP-1s, incretins, twincretins, triple Gs. We're also going to have some light ones where we talk about just skincare. So hang in there with us through the more nitty-gritty sciencey episodes. Thanks again.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.